that trip visited not just Abuja but Lagos, and yeah, it seems like just yesterday that I was there. I can't believe it was 3 years ago already. So I'm just sharing my screen and then we'll get started. Okay. So I hope you can see my slides now.
Yes, very clear.
Great. So as Ahiga just mentioned, I am well aware that Nigeria has one of the highest rates of twinning in the world. And actually almost half of the world's twins are born in Africa. So I'm very relieved that I don't have to give you a talk on delivering twins, because I'm quite sure that you all have more experience than I do in that area. But I'm very happy to speak to you about the role of ultrasound in managing multiple gestation. And we do obviously have twin pregnancies here in Australia, just not at the same rate that you do in Nigeria. This is an example of some Indigenous rock art. And if I zoom in on this area at the top, you'll see a very old image of a twin pregnancy, very different to most of the images that we'll be looking at today. I'd just like to point out this ISUOG guideline in the role of ultrasound in twin pregnancy as a very useful, probably the key reference article that I will be using in my talk today. And if there's any particular point I make that you're interested in, or you'd like to know some more references, this is the main article that I would suggest you go and look at to start with. So the outline of my talk today is that we will go through the use of ultrasound in twin pregnancy in each trimester. So the uses in the first, second and third trimester. And then at the end, I'll focus specifically on some of the monochorionic complications that ultrasound can be very useful in diagnosing and managing. I would have liked to extend it to talk about higher order multiple gestations, but I think I'll run out of time. So I am mainly focusing on twin pregnancy today, but most of these principles can be extended to higher order multiples as well. So let's start with the first trimester uses of ultrasound. And although it's a fairly basic topic, I really wanted to highlight the importance of dating in twin pregnancies, which is ideally done between 11 and 14 weeks gestation. In Australia, a majority of women would present for care by that stage of pregnancy, and I know that's not always the case in Nigeria. And most women here in Australia would be referred for an ultrasound and have the ability to diagnose and date the twin pregnancy by that stage. It is important to understand which measurement you should use for dating in twin pregnancy. So there's been a number of theories over the years, and the smaller CRL has been used. You could also use an average of the two CRLs. But based on expert opinion, the recommendation now is to use the larger crown rump length to date the pregnancy, and that's so that you minimise the chance of missing fetal growth restriction later in the pregnancy by using the earliest due date possible. So dating the pregnancy enables accurate determination of gestational age, and that enables optimal management of preterm birth, and particularly iatrogenic preterm birth when you're trying to make decisions around whether it's safe to deliver a twin pregnancy at a certain gestation. And it also enables much more accurate diagnosis of fetal growth restriction if you have an accurate due date. Now, the second use of ultrasound in the first trimester is determining chorionicity, and we all know as clinicians that chorionicity is much more important than zygosity, which is what most patients ask you about, whether the twins are identical or not. And internationally, the rate of dizygotic twins is about 70% to 30% monozygotic. In Nigeria, the rate of dizygotic twins is higher, so about 80%, and in Australia it's slightly less at about 60%. So we see a higher proportion of monozygotic twins within our overall twin population than you would. And obviously all dizygotic twins end up being dichorionic, and some of them will have a fused placenta, which is why it's not always possible to determine chorionicity based on the number of placentas. Whereas monozygotic twins can divide early and have 2 placentas, so be dichorionic, but a majority of them are monochorionic, and then a very small proportion are not just monochorionic, but also monoamniotic. And we know from pretty good quality studies that it's easiest to determine the chorionicity in the first trimester. So this study from 2011 showed that at 10 to 14 weeks, we were able to correctly diagnose chorionicity in almost 100% of cases. Whereas this older study that looked at pregnancies at a greater gestation showed a rate of incorrect diagnoses up to 20%. And we'll have a look at some of the signs in the first trimester that enable us to determine chorionicity so accurately. And the number of signs that we can look at in the second trimester is greatly reduced because most of those first trimester signs are difficult or impossible to see. So in the first trimester, dichorionic twins early on are very easy to determine because they have 2 separate chorionic sacs. So you can see one chorion around this sac and one chorion around this sac, and in each will be a yolk sac and a fetus. And it forms a very thick dividing membrane because there's the amnion, the chorion, and then the chorion and amnion of the other twin. As the gestational sacs become bigger, you can see this, the membrane becoming compressed and looking a little bit thinner, but it's still very obviously a thick dividing membrane. And by 9 weeks, that membrane's becoming much thinner, but there is still a thin rim of chorionic tissue within that membrane. By 12 weeks, the membrane itself is relatively thin, but if you look at the membrane insertion to the placenta, you should be able to see the chorion extending up from each of the placenta into the membrane. And that forms what we call the twin peak sign, which can also be called the lambda or delta sign. And it's easiest to see in the first trimester because as the twins get bigger, they quite often are situated right over that area, and it can be very difficult to see the membrane insertion. And from 16 weeks onwards, really the only sign that we have is the thickness of the membrane, and that can be quite difficult to use to determine chorionicity. In contrast, monochorionic twins have a single chorionic sac, so at 6 weeks they look very different to dichorionic twins with this single chorionic sac. They'll have 2 yolk sacs and 2 embryos, and at this early gestation, the amniotic sac itself is often very difficult to see, whereas by 8 weeks you can just start to see the amniotic sac developing around each twin. So it's very common in an early first trimester scan for twins to be diagnosed as monochorionic and monoamniotic, and then later on in the first trimester you find that there actually is a membrane. As the amniotic sacs get bigger, they are obviously closer together and are compressing this empty area around the amniotic sac, and that forms after 12 weeks a sign that we call the T sign, and we'll have a look at how that develops now. So at less than 9 weeks, the monochorionic twin pregnancy has a very thin membrane just consisting of the 2 amnions. The dichorionic pregnancy has the very thick membrane consisting of the 2 chorions and the 2 amnions. Whereas at around 12 weeks and onwards, the monochorionic twin pregnancy forms this T sign with no chorion in between the membranes. And the DCDA twin pregnancy has this lambda sign, which if we highlight it here, has the chorionic tissue extending down between the membrane. And I'm sorry if it seems like I'm labouring this point, but I think it's one of the most important uses of ultrasound in twin pregnancy, because if we don't diagnose the chorionicity correctly, then it's very hard to manage the rest of the pregnancy appropriately. And then the rare situation of monoamniotic twins in the first trimester, obviously there's only one amniotic membrane and the twins are usually very closely associated. And as the pregnancy progresses, you can see this twin pregnancy looks like the cords are entangled on the B mode image here. And if we use colour Doppler, you can confirm that there is indeed cord entanglement. I'll just play that video. So you can confirm the cord entanglement, which is suspected just by looking at that image, but you can confirm it by using pulse wave Doppler over 2 arteries and confirming that there are different heart rates in each of the arteries that are closely associated. And then the extreme example, which I'm very impressed that Ahiga remembered that was one of the diagnoses I made in Benin-City, is of conjoined twins, which is very easy to diagnose in the first trimester because the twins are obviously very closely associated and aren't able to be separated. They can be joined at any part of the body, really. This image on the left is from the White Journal and is one of the more common forms of conjoined twins, which is omphalophagus, and this is quite a rare form of conjoined twins that I saw a few years ago, which is joined at the head and the chest. And it can actually be much harder to diagnose at later gestations because most twins are very closely associated as they get into the 3rd trimester, and it can be really difficult to confirm that they're actually conjoined, not just sitting right next to each other. And that's the situation we were in Benin-City. The third important use of ultrasound in the first trimester is labelling of twin pregnancies, and this article that I've put here is an excellent and really clear reference article on how to systematically label twin pregnancies and why that can be so important. And I'll just briefly summarise it in one slide, but if you want more detail, please refer to that article. So the best way to label a twin pregnancy is by the location of each twin within the uterus. So usually the most common scenario is that they're situated on the right or the left, and once the gestational sac and placenta has implanted in that location, it's not going to move. So the twin's not going to move from the right side of the uterus to the left side and vice versa. About 10% of pregnancies, the implantation is actually in a upper and lower orientation, and the reason that it's so important to label them like this, as opposed to the more old-fashioned way of labeling them as twin 1 and twin 2, is that twins who are situated on the left and right can actually switch which is the presenting twin quite easily, as you can see in this graphic here. The twin on the left, who is actually presenting, so is closer to the cervix, if that twin just moves superiorly within its sac, then it's no longer the presenting twin, and actually at subsequent scans it might look like this twin on the right is the presenting twin. And that's really important to continue to label each twin appropriately at each scan, because if we're monitoring fetal growth, we need to be comparing the same twin each time. And there are particular situations in which we need to know immediately after birth which twin is the at-risk twin. Say if there's a cardiac abnormality or something, some other abnormality, then we need to know which twin we're expecting to have that abnormality. There are occasionally other ways of working out which twin is which at each scan, but they're not always useful. So if the twins are a different gender, if they have placentas that are completely separate and on opposite sides of the uterus, or if they do have a fetal anomaly that's easy to distinguish at each scan. And for MCMA twins, it's not usually possible to determine which one's which, because they're always the same gender, they're in the same sac, they can move around the uterus, and they won't stay to the left or the right of the uterus. So it is not possible to confirm for sure which twin is which. And the final thing I'll talk about in the first trimester is aneuploidy screening, which we would offer routinely for all women with twin pregnancies here in Australia. I know that it's not commonly used in Nigeria, but in Australia we would offer everybody this option. And the two best forms of aneuploidy screening, which have been quite well researched in twin pregnancy now, are non-invasive prenatal screening, which has a reduced sensitivity in twins compared to singletons, but is still a very good screening test. Or the combined first trimester screen, which uses the first trimester analytes and the nuchal translucency, and again has a reduced sensitivity compared to singletons, but is still a good screening test. And the only caveat there is that if there has been a early twin demise, otherwise known as a vanishing twin, then these analytes would not be possible or accurate to use. And so it's recommended that just the nuchal translucency and maternal age is used for aneuploidy screening. And the other important thing to keep in mind with aneuploidy screening is that it's possible to report the risk per fetus or per pregnancy, and it's really important to understand which of those the laboratory is using to be able to interpret the information for your patient. And that's usually based on knowing the chorionicity, which is another reason that chorionicity determination is really important. So that's just a quick run through of how we use ultrasound in the first trimester in twin pregnancies, and I can't emphasize enough how important these first two are in planning the management of the whole rest of the pregnancy. So if you ever find yourself in a situation of doing a first trimester dating scan, make sure that you do more than just check the two fetal hearts and have an attempt at least of dating and determining chorionicity. So moving on to the second trimester now, the most common use of ultrasound in twin pregnancy in the second trimester is assessing for structural anomalies. You can actually do that in the first trimester, which I'm sure you know. In singletons, we can pick up at least half of major structural abnormalities in the first trimester, and I don't have the figure for twin pregnancies, but they're more difficult to scan, so it's probably a slightly lower pickup rate in the first trimester. But in any case, we would always reassess the anatomy in the second trimester when we are able to pick up more structural abnormalities. And it does take longer to assess both fetuses, so it's important to leave enough time in your with your ultrasound to assess both fetuses' anatomy. The rate of anomalies per fetus is, per pregnancy is higher in twin pregnancy. So in a dizygotic twin pregnancy, the rate per fetus will be the same as in singletons, but that doubles the risk per pregnancy to 1 in 25. And in monozygotic twins, the rate is 2 to 3 times higher due to that early division of the embryo. And that results in an overall pregnancy risk of anomaly of about 1 in 15. And by the time you're looking at monochorionic, monoamniotic twin pregnancy, they have about a 1 in 6 risk of finding one abnormality per pregnancy. So the risk is much higher than in singletons. In terms of which abnormalities are more common, this is the list here, and you can remember it fairly easily because they're all the central abnormalities. So the rate of skeletal problems and limb problems is not increased, but most of the central abnormalities are increased in twins. So if a structural abnormality is identified, or if first trimester screening comes back as high risk for aneuploidy, then we would always offer and discuss diagnostic testing. It is more complicated than in singletons, partly because the miscarriage risk is known to be higher. With a CVS, the miscarriage risk is up to 2 to 3%, and particularly if you are sampling 2 separate placenta, which means inserting the needle twice. That increases the risk of miscarriage. And with amniocentesis, you have the miscarriage risk, and there's also the added risk of sampling the same sac twice. It's actually relatively easy, even if you're intending to sample 2 different sacs, to accidentally put the needle through the very thin membrane between the twins and actually sample the same twin twice. So you have an increased risk of inaccuracy of the results. If the diagnostic testing shows a chromosome abnormality, or if there's a major structural abnormality, then we would always discuss the option of termination here in Australia. And I know that practice is different in Nigeria and will be different in every country around the world, depending on laws and local practices. But the options for termination of a single twin depends on the chorionicity again. So in a DCDA twin pregnancy, it's possible to do selective feticide by using an intracardiac injection into one twin, because the twins don't share a circulation. So whatever medication you give to one twin will not affect the well-being of the other twin. And preferably you would do that in the first trimester if the abnormality was diagnosed that early, because it has a lower risk of miscarriage and preterm birth. With monochorionic twins, unfortunately, you can't use any sort of intravascular injection technique because it will be transferred to the other twin as well. And so the only option is umbilical cord occlusion from about 16 weeks gestation. And in Australia, we would do that by either intrafetal laser or radiofrequency ablation. And both of those techniques are more invasive than an intracardiac injection. because the calibre of the instruments used is bigger. And that leads to a higher risk of complications, so at least a 20% risk of miscarriage of the whole pregnancy and a 20% risk of preterm birth less than 32 weeks. So quite significant risks to the other healthy twin, which makes it a really difficult decision for most parents. The next thing we can look at in the second trimester is the cervical length. And just because we can look at something doesn't mean that we should. So I'll give you all the information here before you decide whether you should be measuring the cervical length in twins. We know that preterm birth is really common, and the question is, are we able to identify those at highest risk of spontaneous preterm birth? And we know that measuring a short cervix on a second trimester ultrasound does give an increased risk of preterm birth, but unfortunately the exact cutoff to use is controversial and the sensitivity of the test is quite low. So if we're trying to use it for changing our management, so for example in Australia, many women, it's a big country much like Nigeria, and many women would live a long way from an obstetric hospital, if not a tertiary hospital. And so if women with twin pregnancies who are identified to be at high risk of preterm birth, we could ask them to move closer to a tertiary hospital because of the risk of preterm labour. But the sensitivity of the test in this paper by Romero in 2010 was shown to be about 40% if you use a cervical length of 20 millimetres. So that's not a very good sensitivity. It means that we're not detecting 60% of women at high risk of spontaneous preterm birth. So it's not a great test. The other question is, for that group of women that we are able to detect, do we have an effective treatment to prevent preterm birth? And we know from pretty good evidence now that bed rest and oral tocolytics unfortunately are not effective. Cervical cerclage is quite possibly effective with a very short cervix. So there was the paper published last year in the American Journal of Obstetrics and Gynecology, which showed that if your cervical length is over 15 millimetres, cerclage is not beneficial, but if it's less than 15 millimetres or even open, then rescue cerclage can be beneficial in twin pregnancy. An Arabin cervical pessary is a newer treatment, and there's been multiple studies looking at this already, which have had very mixed results. So we don't know if that's useful or not in twins. And progesterone, which has probably been one of the most promising treatments in singletons. Again, there's been quite a few studies in twins now, and it possibly is effective in reducing the rate of preterm birth in twins. But you can see from this meta-analysis here that the overall result of all of the studies shows a slight improvement in preterm birth, less than 33 weeks gestation, but a majority of that effect is from this one large study, which has some methodological flaws, and all of the other studies are quite small and have wide confidence intervals that cross one. So there is still some doubt about whether progesterone is as effective in twins as it is in singletons. So in the absence of many treatment options, we don't really know if it's useful to measure the cervix or not. And so in Australia, there are certainly very mixed practice, and some places would measure the cervical length routinely and other places wouldn't. And you can always tell if there's not good evidence for a particular practice because everybody does something different. So I think the jury's still out on whether we should be using that in the second trimester in twins or not. And then unfortunately, in the second trimester, one of the uses of ultrasound is in diagnosing intrauterine death of one twin. About 5% of all twins have a single intrauterine death in the second or third trimester, so it is relatively common. And the reason that it's important to diagnose the intrauterine death is because of its impact on the co-twin, which depends on the chorionicity again. So DCDA pregnancies, there is a small risk of death to the co-twin, but the main risk is preterm delivery, which is over 50%. And in monochorionic twin pregnancies, the main risk is of death or neurodevelopmental impairment in the co-twin, with also a very high rate of preterm delivery. And that risk of death and neurodevelopmental impact on the other twin is due to exsanguination of the healthy twin into the blood volume or the space of the dead twin. And because of that, the healthy twin or the live twin can become anemic soon after the death of the co-twin. So the management here in Australia would be to monitor for anemia with an MCA PSV during the first week after IUD, and then to monitor for the risk of growth restriction with fortnightly ultrasounds, and to assess for neurological damage, which becomes obvious on imaging about 4 to 6 weeks after intrauterine death. So we would do a specialised neurosonogram and usually an MRI as well to assess the brain of the live twin. So that's a quick run through of the use of ultrasound in the second trimester. In the third trimester, the primary use of ultrasound is in monitoring growth and well-being, and particularly trying to detect fetal growth restriction. So the ISIOL guideline outlines the recommendation for the frequency of scans in dichorionic twin pregnancy, which is roughly every 4 weeks from 20 weeks onwards, and that's mainly to detect fetal growth restriction, and the increased schedule in monochorionic twin pregnancies, which is fortnightly from 16 weeks. And in the first half of pregnancy, that's partly to detect twin-twin transfusion syndrome and partly to detect very early FGR. And in the later gestations, it's primarily to detect growth restriction. So why do we monitor growth so closely? It's because twins are at an increased risk of growth restriction due to placental reasons. And we know that growth restriction increases the risk of fetal loss and neonatal morbidity. So detecting growth restriction enables us to hopefully time delivery to reduce that risk of fetal loss and other neonatal morbidity. We need to know how to define growth restriction in order to detect it, and the actual definition, as I'm sure you know, is the same as in singletons, which is a fetus that fails to reach its growth potential. But that's a very difficult thing to detect on ultrasound, so we need to use the proxy of a small for gestational age fetus, which is usually defined by an estimated fetal weight less than the 10th percentile. But in twins, we do have the added advantage of a co-twin to compare the size to, and presuming that all twins come from similar genetic material and are housed in a similar environment in the same uterus, then we presume that their growth should be about the same, and particularly monozygotic twins who have exactly the same genetics should have exactly the same size. And so we know that an inter-twin estimated fetal weight discordance of more than 20 to 25% is another part of the definition of growth restriction in twins. And the way to calculate the estimated fetal weight discordance is to use the difference in the EFW of each twin and divide it by the estimated fetal weight of the larger twin. The next question is which growth charts to use, and that's a hard enough question in singletons, let alone in twins. But we know that we should be using charts based on estimated fetal weight, not birth weight, and they should include measurements of the head, abdomen, and femur. The main question in twins is whether to use singleton charts, where the twins should be growing at exactly the same rate as singletons, or whether it would be better to use specific twin charts which have been produced. So this is one example of twin charts from a group in the UK that were published in 2015. And these are the individual biometry measurements, and you can see the dotted line on each chart is the average for singletons, and the darker line is the average for DCDA twin pregnancies, and you can see that the twin pregnancies fall off slightly, particularly after 30 weeks for each of the 4 biometry measurements. And this exactly the same pattern occurs with monochorionic twins, where the growth of each parameter is reduced in twins, particularly later in gestation. But the reason that it's controversial as to whether we should be using twin charts is that this fall off in growth might actually be pathological and might actually represent some degree of placental insufficiency. So perhaps it's better to compare them to healthy singleton pregnancies, which is how they should be growing. So I don't have the right answer to that, but I can tell you that most places in Australia use singleton charts to compare twins to. And it's very common to see that the twins are lower on that chart after 30 weeks. I'll just briefly touch on the management of growth restriction. You could talk about this for an hour just on its own. But in dichorionic twins, but essentially the principles are the same as in singletons. We'd be monitoring the fetal growth more frequently, every 2 weeks, and would also be monitoring the Doppler studies for progressive deterioration and the biophysical profile and amniotic fluid volume as well. And the timing of delivery is really based on the risk-benefit assessment from these markers of fetal well-being, balanced out against gestation. And that risk-benefit assessment is going to be different depending on where you work and what your access to neonatal facilities are. So there's no specific answer to when growth-restricted DCDA twins should be delivered. And then monochorionic twins are even more difficult because there's very limited evidence for how to manage growth restriction in these complicated pregnancies. But I'll talk about that more in just a moment. So the last 15 minutes, I'm going to talk about the monochorionic complications, and I'll start with the type of growth restriction that happens in monochorionic twins, which is termed selective fetal growth restriction. So just going back to a little pathology lesson, it's really important to understand what happens with the monochorionic placenta, to understand why some of these conditions occur in monochorionic twins. I'm sure you all know that there are multiple types of anastomoses which enable communication between the twins' blood circulations. And there are bidirectional and unidirectional anastomoses. So most monochorionic placentas would have one arterio-arterio communication. And this image from the paper that I've listed down the bottom there shows really nicely the artery from one twin, which has got red dye injected, and the artery from the other twin, which has white dye injected. And here where the star is, there's a AA anastomoses, which has allowed some of the red dye to move through into the other twin's circulation. So that's the one AA anastomoses on this monochorionic placenta, and it allows bidirectional flow of blood, which is actually protective against some of the complications that we'll be talking about. VV anastomoses are rarer, and we don't know their exact function. And then unidirectional anastomoses are that arteriovenous connections, and they're very common, and there's usually multiple AV anastomoses in each direction on a monochorionic placenta. So on this placenta, the easiest one to appreciate is this artery, which is anastomosing with this vein that has purple dye in it. So this circle here is an AV anastomoses, and in this paper they've circled each of the AV anastomoses with the darker circle, and then the VA anastomoses in the opposite direction they've circled with the little dots here. And you can see that there's about the same number of AV anastomoses in each direction, and that leads to balanced flow between the twins. So this placenta resulted in a healthy monochorionic twin pregnancy with no complications. And over the next couple of slides, when I'm looking at the placental pathology, I'm going to be using quite a few examples from this paper. And if you're interested in knowing more about the pathology of monochorionic complications, I can highly recommend looking at this paper in more detail from this group in Belgium. So back to selective fetal growth restriction, which happens in about 10 to 15% of monochorionic twins. And it happens because of unequal sharing of the placenta. So you can see in this example here that there's one twin that has a central cord insertion, and its vascular supply is from almost 3/4 of the placenta, whereas the other twin has a filamentous or marginal cord insertion and has a much smaller share of the placenta. There are vascular anastomoses in this placenta, which is usually protective to the small fetus because it allows some transfusion of blood from the larger fetus to the smaller fetus. And as I mentioned before, the diagnosis is based on not just the size of the smaller twin, but also the weight discordance between the twins. And in monochorionic growth restriction, there is a classification system into 3 different types of selective fetal growth restriction, which we'll look at now. It's summarised in more detail in this paper here from 2007. And it's a classification system based on the findings in the umbilical artery Doppler of the smaller twin. So type 1, you would find positive end-diastolic flow in the smaller twin. Type 2, you would find persistent, absent or reversed end-diastolic flow in the smaller twin. And type 3, you find that there's a cyclical pattern of intermittent, absent and reversed end-diastolic flow. So if I just zoom in on each portion of this pulse wave trace, you can see that here there's absent end-diastolic flow. As it continues on, there's positive end-diastolic flow. And as it continues on to the end, there's an area of reversed end-diastolic flow. And that pattern would just continue as long as you listen to the umbilical artery Doppler. And these three types of selective IUGR give different outcomes and are due to slightly different pathology. So in type 1, which has positive end-diastolic flow, we see a less marked discordance between the weight of the twins, and that's because there's sufficient anastomoses that the smaller twin is getting some blood supply from the larger twin. And the outcome for these pregnancies is usually very good, with a fairly low rate of intrauterine mortality, even if we don't intervene. Type 2 is where there's persistent absent or reversed flow. And this is usually a type of pregnancy where you see a very severe discordance in weight. On the placenta, there's usually less anastomoses, so then less protection for the smaller twin. And this is usually very prone to progression as you monitor the pregnancy. So if we don't intervene, 90% of them will lead to in utero deterioration. And then type 3, which is the intermittent cyclical waveforms, is usually because of very large AA anastomoses, which often occur when the cord insertions are very close together. And there's a really large caliber AA anastomoses that allows a large transfer of blood volume between the twins. The overall outcome is a better prognosis than type 2, so it doesn't usually progress as surely as type 2 does. But unfortunately, because of the large transfer of blood volume, it can lead to unexpected fetal death in about 15% of cases, which makes it very difficult to know how to manage, because even if we monitor them frequently, this intrauterine fetal death can occur without any warning. And it's not possible to deliver them all before that happens. So that's a brief summary of selective fetal growth restriction in monochorionic twins. I haven't gone into management because, as I mentioned before, it's really not very evidence-based how to manage these twins, but certainly it's very common in monochorionic twins to end up with preterm delivery because of these findings. So the next MCDA complication that I'll cover is twin-twin transfusion syndrome, which occurs because of an unbalanced set of anastomoses. So the unidirectional anastomoses are predominantly in one direction, either AV or VA between the twins. And this is an example of a placenta like that, where there is one AA anastomoses, which is the protective type, but all of these circles here are AV anastomoses in one direction. So you can see that there's no anastomoses in the other direction to balance that out. And that results in a net transfer of blood from one twin to the other. And that gives a set of abnormalities, which is quite easy to pick up on ultrasound. So I'll just go through a bit of detail about the ultrasound findings now. The staging is the Quintero staging, which I've got the reference down the bottom there, and I'm sure you're all aware of, and we'll just go through that, the ultrasound findings of each stage now. So the oligopoly sequence is the first thing that we usually see. This is a normal example where there's quite concordant amniotic fluid volume in each sac, and this is an example of discordant amniotic fluid volume where there's obviously much smaller volume of fluid here than there is in the other sac. And the actual definition is that you need oligohydramnios of less than 2 centimetres and polyhydramnios of greater than 8 centimetres in each twin. As it gets worse, you can start to see the membrane draping around the limbs of the smaller or donor twin. And the sort of final stage of oligohydramnios is when the membrane is suctioned around the smaller twin, and we refer to that as a stuck twin, which I'll show you some images of now. So this first clip, you can see the membrane's actually very difficult to see, and that's because it is stuck so closely around this twin. And in this clip, you'll see that the twin at the top here is looks like it's stuck to the roof of the uterus. And I will always remember one of my mentors here telling me that that defies gravity. So that is never a normal finding, to find that one twin is stuck to the top of the uterus and doesn't move away from there. So you always have to be thinking that that twin has anhydramnios and is stuck in that position. It can be difficult if the donor twin is cocooned in a membrane, as shown in this graphic here. That leaves it looking like it has a stalk of membrane coming from the uterine wall, and then the stuck twin is actually not against the uterine wall but floating around in the middle of the polyhydramniotic sac. And the stalk looks like it connects to the uterine wall. So on ultrasound, that looks a little bit like this, and you can see that it would be really easy to measure this as the deepest vertical pocket, but actually it's not. And you need to look much more closely around that fetus's limbs, where you can often see a tiny bit of fluid in between the two layers of membrane. So stage 2 is an absent bladder, which I think you would all know how to identify that, but yeah, you just don't see any fluid inside the bladder, and you can confirm that that is the right area of the bladder by looking at the umbilical arteries. And the recipient twin usually has a very large, tense looking bladder in comparison. Stage 3 is abnormal Doppler studies, and specifically it has to be absent or reversed flow in the umbilical artery or reversed flow in the ductus venosus in either twin. But most commonly you would see the umbilical artery abnormalities in the donor twin and the ductus venosus abnormalities in the recipient twin. Stage 4 is hydrops, which just looks like hydrops of any other cause. And stage 5 is demise of either fetus, which obviously we're trying to detect and manage this condition before it gets to that stage. Now, unfortunately, there is a bit of overlap between the two conditions that I've talked about so far, and about 50% of patients with twin-twin transfusion syndrome will also have selective IEGR. So it can be really difficult to categorise the ultrasound findings into one or the other when there is a bit of a mixed picture. But the key points that I would highlight is that for it to be twin-twin transfusion syndrome, there needs to be polyhydramnios in the recipient twin, which is not usually the case if it's purely growth restricted. So that growth restricted twin will have oligohydramnios, but the other twin won't have polyhydramnios. Again, in selective IEGR, the larger twin won't have a large tense bladder like they do in twin-twin transfusion syndrome. And in the recipient twin, in twin-twin transfusion syndrome, there might be abnormalities of cardiac function, which you wouldn't expect in a normal sized twin of selective growth restriction. So they're the tips I have in determining whether it's definitely a twin-twin transfusion syndrome picture. So again, I've just briefly tried to cover management, which you could talk for hours about. But stage 1 or even pre-stage 1 twin-twin transfusion syndrome can be managed quite successfully with conservative management, so just monitoring for weekly progression, and has a fairly good survival rate. But we know that the survival rate is pretty similar with fetoscopic laser ablation, if that's an option. So the theory of that is that we use an endoscope to go into the uterus, look at the placenta, and ablate those abnormal vascular connections that I was showing you. Amnioreduction isn't recommended for stage 1 because studies have shown that the survival rate is less with amnioreduction than with the other two options. And then with stage 2 or more, conservative management leads to a very poor chance of survival, because the most common scenario is that these would progress through the stages. So the recommended treatment is fetoscopic laser ablation, and that leads to survival of at least one twin of 70 to 75%, with a risk of neurological morbidity in that surviving twin. And there is also the risk of recurrent twin-twin transfusion syndrome, and that can be reduced by using the Solomon technique, which is shown in this image here, where they've used laser to ablate the abnormal anastomoses, but they've also ablated the entire vascular equator, which reduces the risk of recurrence. If laser ablation is not an option, then serial amnioreduction does give a survival of at least one twin of 50 to 55%, and that's better than conservative management in stage 2 or more. And it has a higher rate of neurological morbidity than laser ablation, but still a reasonable chance of intact survival for the remaining twin. And if the condition is very severe, then obviously you could either manage it conservatively, counselling about the risk of double intrauterine death, or you can offer selective termination for one twin, which can lead to survival of the other twin of about 85%. And again, as I explained earlier, that would involve ligation of the umbilical cord of one twin, and does carry a very high risk of rupture membranes. I thought you might be interested to see what it looks like at the time of laser. So this is using an endoscope to look at the placental anastomoses. It's just a 30-second video because I know we're getting close to running out of time here. And this shows a vein here and an artery that with darker blood in it here, and they're anastomosing there. So it's an AV anastomoses. And this is the laser fibre which is being used to ablate that abnormal AV anastomoses. So that's the process of laser, and it involves going along the whole vascular equator and mapping out each of these AV anastomoses that we saw in the pathological specimens that I showed you. And finally, another MCDA complication is the twin anemia polycythemia sequence, which you can see on pathology quite easily without injecting the placental vessels, because half the placenta looks very pale and anemic and the other half looks very hyperemic and red. And sometimes when the fetuses are born, they have a very similar appearance. On ultrasound, you can often see a difference in the two halves of the monochorionic placenta. So the anemic half of the placenta is brighter on ultrasound and is very thick and hydropic looking, whereas the hyperemic part of the placenta is very thin looking. And the other main way that we detect this condition on ultrasound is by looking for fetal anemia, which we do by using the MCA-PSV measurements. And the antenatal criteria for diagnosis is that the MCA-PSV is more than 1.5 mom in the anemic fetus and less than 1 mom in the polycythemic fetus. And you can stage the disease according to how severe those abnormal MCA-PSVs are. It's actually quite difficult and uncommon to detect antenatally, and it's more common to detect particularly the less severe cases postnatally. So the postnatal criteria are a difference in hemoglobin and either a reticulocyte ratio greater than 1.7 or the typical placental pathology that we see. So if you were to inject these vessels, what you would see, the underlying pathology, is very tiny calibre, usually less than 1 millimetre, AV anastomoses which are unbalanced. So they're usually fewer and much, much smaller in calibre than the anastomoses that cause twin-twin transfusion syndrome. And the theory is that that leads to a much slower transfusion and much less volume transfusion of blood between the twins, leading just to anemia and polycythemia rather than all of the other sequelae of TTTS. So on ultrasound, as I mentioned, we measure the MCA. You need to measure it properly. It's very easy to get an abnormal result due to fetal breathing, so you have to make sure that you're getting the fetus when it's still and not breathing. And obviously what you're looking for is the highly discordant MCA PSVs. I haven't put in a slide about management here because there's really no good evidence about how to manage antenatally detected TAPs, but the options would be to transfuse the anemic fetus if the gestation is very early, or to perform laser to try and ablate the anastomoses, or if the gestation is a little later, to deliver the babies to allow postnatal assessment and transfusion as required. And then the very last MCDA complication that I'll talk about is the other one that I detected on my visit to Nigeria, which is twin reversed arterial perfusion, which is very easy to diagnose in the first trimester because you see one healthy looking twin and one twin that has very abnormal anatomy. So usually there's no head or heart. So what you see is an amorphic mass that does not have its own blood supply. And you can confirm that that condition is there by looking at the blood flow within this abnormal mass and confirming that the umbilical artery has flow to that mass rather than flow away from it, which is what it would have if it had its own cardiac supply. And that condition, as you can read in the ICUR guidelines, can be managed successfully by ablating this vessel and dividing the connection between those twins, which leads to a fairly good chance of survival in the normal or pump twin. So I'll leave it there because I've already gone 5 minutes over time. That was a very quick summary of the role of ultrasound in each trimester, and I'm happy to answer any questions.
Yeah, Alice, thank you very much. It's been a really wonderful one. I didn't expect anything less from you. And you asked how many persons, despite the difficult time that we put it, we have about between 230 and 240. So I think that's great.
That's very impressive, and I thank you all for taking the time out of your busy days to listen to this talk. I really hope that at least one part of it has been useful for each of your clinical practice, because I know it was a fairly quick summary of each of the uses of ultrasound.
So I'll